everyone. Good morning, good afternoon, depending on where you are today. My name is Saki Malik-Cho with the National Center for Health and Public Housing. Welcome to the fifth and the final session of the SDOH Screening Tools for Public Housing Residents Learning Collaborative. Thanks again to all of you for making the time to attend today and for all of these sessions. We are going to discuss accountability, navigating reimbursement, and evaluating impacts. And with us again is Dr. Zara Marsellian, the CEO of La Maestra Health Center, to help with that discussion. The National Center for Health and Public Housing is a national training and technical assistance provider. We're funded by the Health Resources and Services Administration to strengthen the capacity of health centers that serve public housing residents. However, the views that we are expressing today represent our own, don't represent those of the government. Since this is our fifth time together, just to remind you that we hope to have an engaging session, feel free to turn on your video. The chat is open. We encourage you to use it throughout the session. You are muted right now, but if you would like to be unmuted, just use the raise hand icon and we will unmute you. We are recording the session. The slides and the recording will be posted to Moodle. We'll also be sending it by email. We're also going to post all of our slides and recordings to our website so that they can be easily shared to others. So please go ahead now, introduce yourselves in the chat so that we can all see who's here today. Enter your name, your health center, and your location. You can go ahead and do that. Say hello to everyone on the line. You all know who we are. My name is Saki Malik-Cho, Director of Research Policy and Health Promotion here at the National Center. I'm joined with Dr. Abdeen Naboya-Rios, who's going to help moderate. My colleagues, Fide Pineda-Sandoval, Chantel Moore, who are also helping with other aspects behind the scenes of this learning collaborative. Again, Dr. Zara Marsellian is joining us today. She's the founder and the CEO of La Maestra Health Center. She's got more than 30 years of experience to share with us. You can find her full bio in the welcome packet. It's a great pleasure, of course, for us to have her here. And as you did during the last session, I encourage you to take advantage of this time, ask her any questions about the points that she makes during her presentation. So here's our agenda today. I'm just going to remind you about the topics that we've covered so far. We'll have a very brief overview of today's session. I'm also going to highlight a resource on SDOH codes that will provide some background for Dr. Marsellian's presentation and her comments. And then she's going to do her presentation. We're going to do a similar format as the previous session where it's a guided interview Q&A process. And we hope that you all will chime in with your questions and comments throughout her presentation. And just a reminder about the evaluation at the end of the session. We're going to be having two evaluations during this learning collaborative, this sessions. At the end of the slides, we'll have the poll for the evaluation of this specific session, but then we also have an evaluation for the full LC. I put the link to the SurveyMonkey in the chat, and then we'll also have that link at the end. It's really important for us. It helps us understand what's going well and what needs some work, and we can respond accordingly. We'll also send a certificate of completion for attending the learning collaborative for those of you that fill out that survey. So we've covered quite a bit during the previous sessions. We have had a screening 101 going over the basics of SDOH and the screening process. We had a guided tour of screening tools and spent some time on the Prepare tool and the Child Well Visit Planner. We also discussed the importance of implementing a screening process with whole families in mind, building trust between patients and providers, and streamlining the reporting processes. And we also talked about integrating screening into EHRs and managing workflows, discussing staff capacities and roles as well. And now Abdeen is going to go over our plan for today.
Accountability, navigating reimbursement and evaluating impacts. The learning objectives for today are basically four. Define the SDOH-related Z codes, Describe an evaluation plan for measuring and monitoring the impact of SDOH screening on patient outcomes and health center procedures, as well as list promising practices on reimbursement and funding strategies to pay for SDOH screening and referrals. And finally, summarize key concepts needed to implement an SDOH screening process in your organization.
Thank you, Abdeen. So because we are going to discuss reimbursement, I just wanted to make sure to show you a resource that was developed by UCSF's Social Interventions Research and Evaluation Network, or SIREN. It's a comprehensive spreadsheet of social risk factor codes, and it's intended to help providers identify codes related to social determinants of health. It's organized according to domain, and it includes codes for assessment, as well as interventions and treating conditions or providing referrals. I just have one example for transportation included here. And so you can see that there are Z codes for assessment, problems related to housing and economic circumstances. There are SNOMED codes for transportation problems or lack of access to transportation. And then the referral codes for case management, counseling, and education, as well as services that could be provided, like providing a taxi or transportation. It's a very comprehensive spreadsheet. The link to it is in the slide. There's also the source on the bottom. So I encourage you to take a look at that. Zara will be talking more about her experience using codes like this in just a moment. But before we jump into her talk, I just want to ask you all a couple of questions about reimbursement, and we're going to launch a poll. And I'm going to ask Chantel to help with that poll.
All right, question number 1. Have you used Z codes, SNOMED codes, or other codes for SDOH assessments or treatment? Your choices are yes, no, I don't know, or not applicable. And question number 2, are you receiving reimbursements from insurers for SDOH-related activities? And your choices there are the same: yes, no, I don't know, or not applicable.
Okay, I'm going to end the poll.
All right, for question number 1, have you used Z codes, SNOMED codes, or other codes for SDOH assessments or treatment? 86% answered yes, 0% answered no, 14% answered I don't know, and 0 answered not applicable. For question number 2, are you receiving reimbursements from insurers for SDOH-related activities? 14% reported yes, 29% reported no, 57% reported I don't know, and 0% reported not applicable.
So that's really interesting. Thanks so much for answering those questions. I'm glad to hear that you all are using these codes, but I'm curious about the reimbursement for SDOH activities, and I'm sure Zara will share some of her insight on that as well. So now it's time to talk to Zara. Again, we're going to use an interview type of format. I have compiled a list of questions on a handful of topics that I'm going to ask her. If you all have any follow-up questions or comments, please use the raise hand icon. We'll unmute you, or you can add your questions and comments in the chat. This should be very informal, so feel free to kind of chime in with your questions and thoughts. So welcome, Zara. Thank you again so much for joining us today, sharing with our audience again. I would like to ask you to walk through a case example, perhaps a patient that was referred to your human trafficking unit or a behavioral health patient, and start by describing how the patient was handed off to a community referral. And I would like to know if you have an example of an organization where you have some sort of an agreement with to share information about your patient and how you share that information.
Sure.
Go ahead.
Thank you so much. All of the information that I'm sharing today is based on findings and operations through La Maestra's Circle of Care model, and I just wanted to kind of give that background. It's the model comprises of integrating social determinants of health into the primary care setting, and we've been developing this model over 34 years. So we've had quite a journey on figuring out aspects of, how do you share data? What data do you share? And actually finding that IT solution that seems to be working for us. And I'll share that later again on, how we got to this point and what does that allow us to do. But your question here is, there are plenty of examples. I'll give one that is, it was based in our human trafficking unit. We received referrals from obviously other clients and friends of clients and families of clients that hear about our human trafficking assistance program. And this was a patient that identified as transgender, wasn't a patient yet because they presented to the human trafficking unit. And as they start going through the story of what happened to this person, we were able to connect them right away with our, the DA's office, law enforcement, because the perpetrator that had been persecuting this individual and a group of other transgender from our communities were, being harassed. They were being followed. They were followed to group meetings that we put together so that they had some place to meet in the community, like a support group. And so, aside from that, so the DA's office was able to look into, some of the criminal activities and these perpetrators that were persecuting the transgender community here in San Diego. Also referring this individual to our food pantry because they had a big need around food. The social services, seeing what programs the individual would be eligible for. Going to the medical, for primary care and for hormone therapy, also mental health and immigration services. And this really, I think, brings to light some of the incredible stress that people are under if they don't have their, their
Zara, I think we lost you.
Yeah, I think we did.
She's frozen, right?
Mm-hmm.
Oh, are you there? Let me send her a message through chat.
I'm here.
Okay, sorry, we lost you. It seems like you're frozen again.
Okay, let me see if I can. Okay, good. All right, I don't know what's going on, must be the weather. But in any case, through the food scarcity, housing, shelter, medical, mental health, that was really impacted by this individual's lack of status, immigration status, and not being able then to plan for the future, and so through all of these services in-house and also outside through these established MOUs that La Maestra has with, across sectors, we were able to effectively bring down the resources for this individual and then keep track of the progress. Eventually, the individual did get their legal status. Their feeling safe in a safe environment. The individual went through the microcredit program, started their own business, and then was able to attend through the community colleges for the chef certificate. And that's awesome. So that then was able, because you have the certificate, but if you don't have the legal status, how are you going to work? So all of those really, I would say, services and case management, social services, all went to improve the quality of life and, of the individual. And so that's one example of a patient, eventually became a patient, right? And the cross referrals. I mean, internally, we can manage those referrals very well. What happens when we send and refer people outside the organization for specialty legal, let's say, or any of these other, resources, is oftentimes you don't get something back in writing because the systems don't share information. And so a lot of it's, case management, picking up the phone, calling the person over there at the organization that can give the information. Okay, this is what we did. This is the trajectory, the timeline. These are still identified gaps of, resources that this individual needs, and following up on it. So it's very intense case management. And it's awesome now that we have a central repository for all of the information around SDOH.
That's a really great example. I'm sorry, there's a lot of background noise here. That's a really great example of a patient really utilizing all of those services and getting better and healthier. And the immigration status is a huge one, so that's great. I want to ask you about how you're using that tracking data from your referral repositories you mentioned to measure and monitor the quality of care that you are providing at La Maestra for that patient. So can you talk about just a little bit about quality and how you're monitoring that?
Sure, we do really monitor through the case management and then looking at the outcomes, right? What's the outcome of all of this? We've done research studies from within our populations that can identify the value that they basically assess to the integrated model with social determinants. What difference did it make to them? What value did it bring? So we have that perspective. We also compare that and triangulate that with the HEDIS measures that as a FQHC, we're always looking at and maintaining, evaluating, and improving. And it is a continuous, process improvement on everything that we do. So it's like not just looking at it once, you just got to keep going back and, okay, where are the gaps? And how can we build those correlations between the fact that we do have the social determinants that our population needs, and what difference does that make in terms of their HEDIS scores, especially around chronic disease? So, from a, logical perspective, you can draw the conclusion that if you have diabetic patients, for example, and they have access to nutritious food and health education, that somehow, their scores are going to be better, and they'll be more balanced, and they'll have a better quality of life, and your HEDIS scores will be better. Actually, nailing that down is another story. We're working on ROI, return on investment methodologies right now to look at the fact that, okay, because we do refer to housing and La Maestra does provide some housing, gathering data from patients about their housing is awesome, but we always want to be able to act on it. And what difference does that make? If they're in some stable housing versus being homeless, there's some data that we can assess, especially if the patient is, for example, through our, health homes program, then that data comes from the health plans, the managed care plans. For example, I'll give you an example. One patient had hit the ER 60 times in a year, and for numerous reasons: chronic disease, substance use disorder, mental health issues. And so being part of this, Health Homes program, which is through the California State CalAIM initiative, we were able to say, okay, look, with the availability and the case management of all these other services that will help this individual with the housing and the substance use disorder and the mental health, okay, look, now the same patient has not hit the ER 60 times for these reasons. So that's kind of like an easy methodology to create. Some of the other social determinants, it's really hard to pin exactly the savings to the system because of the availability of these social determinant services. But we're working on it, and we're doing a lot of education with the health plans, because as they're the ones that are determining what these Z codes are, like for example, United Healthcare, they sent us a whole list of Z codes that they would like us to use to collect data. And it's around food insecurity, homelessness, inadequate housing, job stress, all of that. But they just want us to collect the data. They're not going to pay us anything extra. It's all in our original capitation. So we're working with them because the objective is that CMS will eventually start paying for some of these Z codes, and therefore the health plans will add it on. And I'll describe what kinds of reimbursement we're getting right now.
That's great. We had a question in here from Andres. He says, I'm interested in knowing what insurances are reimbursing, as we are submitting ICD codes to our Medicaid plans, but only as tracking and not for billable services, which is exactly what you just said. Yeah.
And then I wanted to say something about the tracking. A lot of research has come out over these last 5 years around collecting data. And in Europe, they call it social prescribing. So it's not just collecting data, but then you give people a list of, okay, you have housing here, go here and look into possible housing. That isn't enough, because I think that, La Maestra's response has been to either create the service or have an MOU with the organizations that you're referring to. So A, do they have the capacity? Are our patients going to be eligible? Because the last thing our patients need is to have further complications, finally get the transportation to get over to these other agencies that you're referring them to, only to find out that they're not eligible. And many of our patients have, very traumatic backgrounds. And by the time they sit there and they explain over and over and over again their background to see if they're eligible, that in itself is a huge challenge. So social prescribing is, we have to be careful with that. We have to know, really, are these resources out in the community? Are they going to be able to accept our patients? And the only way to know that is to have a conversation with them and come with some kind of a basic MOU template that just says, your organization will accept our patients, you have the capacity, and this is what your procedure is that we will follow for the referrals and tracking. And so that's one piece of it. The other is just collecting data. CMS originally with and through CDC, the Healthy People 2010, 2020, 2030, it's all about collecting data. Well, when we ask the patients numerous questions, unless we tell them, look, we would like to know what your needs are, and we'll do our best to connect you to those resources. However, we cannot give them the impression that just because we're asking them 20 questions about everything they need, that they're going to walk out of there and have all of their needs met. That is another kind of, point of caution I would mention. And what we do is we collect the data for ourselves and then to do the referrals. So in terms of payment, The only payment we're receiving for our SDOH services right now are through these California initiatives. So one is the Health Homes program. The other one is, the chronic case management. They'll allow you to do, extra case management, and HHP will let you have a housing navigator, more case managers, and they will actually reimburse you. Again, it's through the plans, the health and managed care plans. And then again, I mean, it's all new and it's all changing. The models keep changing up, but it is hopeful that we will eventually get to the point that the data we're collecting will then be reimbursed, for those services. A lot of it is educating the health plans. Like, we work with 7 health plans, and some are more advanced. Some understand what social determinants are, and others are kind of like, well, we really don't want to get into that. That's not our bailiwick. Healthcare is our, knowledge base. But I think more and more they're having to actually start participating and eventually reimbursing for these services, because as we all know, in many studies, global studies have shown that the more dollars that are spent on social determinants, the better the quality of health. I think we covered this in our last session. Many European countries, spend 10 times more on social services than actual medical services, and their populations are actually healthier. So, that's something that I hope we can start seeing. But again, it's around these small initiatives that the state of California and the health plans are finally reimbursing for some of these SDOH. Otherwise, La Maestra has always supported, from our operating budget and also from grants that might be, some foundations are, really wanting to give for food scarcity programs. Others for, microcredit for economic development. Some for housing and transitional housing and programs connected to substance use disorder. So it all depends on, the blend of funding until we can get to the point where we're actually reimbursed for these services directly by CMS or through the health plans.
I have a question, just a follow-up about your agreements with the community organizations. Do you all have any ways that you leverage your resources or pay for services together, like some kind of arrangement of back and forth referrals, so that maybe you all also get the healthcare referrals and that can help increase your patient base, anything like that?
Oh, absolutely. I mean, across all sectors. I mean, if we just take the sector of, substance use disorder, we have established networks over the years of collaborating partners. Could be treatment centers, recovery programs, where obviously they have clients that come in that are referred from many places, law enforcement, drug court, probation, but those are not our patients yet. So our partner gets a lot of referrals. They need medical services for their populations. They don't provide those medical services. And so that is the kind of cross referrals that we get, where they'll refer us for new patients.
Danisha had a couple of comments in here. She says, yes, this is one of the most challenging aspects of SDOH data collection, having all of this data to inform programming and services, but not being funded to support them. And she also says, yes, MOUs with mutually beneficial organizations can be highly effective, especially for health centers who don't have these SDOH-oriented programs and services. So thank you, Danisha, for those comments.
Yes, I just can't stress enough. It's best for the patient, and it's best for our organization also to know, who's liable for what. So if they want us to bring certain services, let's say through our mobile unit or a mobile clinic, out to their facility, you know, it's really important to cover all of those other organizational or operational factors like liability, you know, and how those services are going to be paid. Definitely.
Fide, can you unmute Dalmisha? She has her hand raised.
Hi, Dr. Zara. Thank you for presenting today. This has been wonderful. I've been working in this field for a long time, and so it's just good to have a leader like yourself speak about the challenges of collecting and all the work that across the nation is doing, especially from a leadership level. And I just wanted to piggyback about the complexities of dealing with people who have chronic conditions and diseases and whatnot, and needing to have that supportive programming. A lot of my work has been with diabetes and asthma and hypertension. And so with diabetes, of course, we have our medical providers prescribing, you know, medications and going to the labs and things like that. But we know it's a behavior change, right, over time, needing to establish those healthy behaviors. We also know that if you go home and you live in a neighborhood where you're in a food desert or there's corner stores and not really a lot of healthy items to support those things, it makes it even more challenging, right? And so the medical care is there, but those supporting services are not, and just trying to write grants and advocate for funding and all those things. But it's happy to see that leaders like you are pushing and advocating for our voices to be heard. So thank you for that.
Denisha, I also wanted to mention, you know, we have a fantastic asthma mitigation program, and we have an asthma clinic too. And it's amazing how many providers, you know, we'll get new providers that we haven't trained up yet. Maybe you've experienced this too. And it won't occur to them that, you know, it's really important to figure out the housing situation for these kids, because, you know, we'll have, you know, kids that keep coming in that no matter what medication you're giving them, they don't improve. And then it turns out that they're living in a, you know, 2-bedroom apartment, but there's 3 families living in that place. There's not enough ventilation. The carpet's there. It's been like 20 years old. I mean, that's why it's super important to, you know, to have programs where you can actually go do a home assessment. And that's one of the additions that our asthma clinic has added through this grant for asthma mitigation, is to go out and to see what is the contextual environment of these kids and the families. And because no matter, you know, what you do from the medical side, unless you address those other issues, you're not going to get anywhere.
Yes, I agree wholeheartedly. I don't want to take up your time, but yes, this is the work that we have been doing. I'm sure other health centers have been as well. So thank you so much.
It's
And
very
I
exciting.
think it's a good segue into our next question, which is, you know, how have you used this data to secure additional funding opportunities or any other grants?
Well, you know, that is super important. Again, it's all about educating the funders and the potential funders. So it's providing information back to CMS, their innovation center, and all these other agencies, CDC and so forth. Like, look, this is the data. It took us, for example, with these chronic disease patients or with substance use patients, I mean, how much time for the case management? So they're not going to come and give us $30 for the month to deal with the case management aspect of, you know, all this SDOH. That's like educating the government, educating the, you know, public health agencies, but educating the funders, foundations. You know, if you can show data that says, okay, look, out of all, let's say the youth, because we have youth development programs too, aside from, you know, youth medical services. The contextual environment impacts the health status of our youth and the mental health aspect. And if we can show the data of, look, this is the number, this is where they came, this is what they said they needed, this was all of these other really complex layers of challenges that we need to work through. That's the data and information we need to get back to these managed care plans, the government, all these agencies we work with. So they're not making these, you know, vague generalizations and that they understand the extent of the time and the work that we spend on each individual patient. Super important. And then to share, obviously, the outcomes, the improvements in their HEDIS, improvements in their quality of life that they identify, right? Not me putting it out there on them.
That's really great. Thank you for that, Zara. So the final question I have for you is just if you could just give a summary of all of what you've learned at La Maestra and what you would like to share, what kind of advice you'd like to share with the other health centers that are on this call.
Well, I think that, the first point is, the importance of finally taking into consideration social determinants and the impact on people's lives. That's number one. And the resources that we all have that we can further develop and bring down to the community levels to open those pathways for our patients to really benefit from the resources across sectors like housing and food and everything else. That's important. Collecting the data, managing the data. It's been a journey, like I shared on the other sessions with us. We first tried to develop, through QuickBase, through Salesforce, Launchpad, and all these programs that we got through some grants or some we invented ourselves to capture the SDOH, because our EHR, which is NextGen, and other EHRs are similar, they are not built with the fields to capture SDOH data. So especially, let's say, one of these clients is coming in from our human trafficking or immigration or microcredit or youth program. They're not patients yet. So we can't add them into the EHR, right? So after multiple lessons learned and figuring out that our providers and our staff are not going to get off a NextGen or EHR to jump on to another system to capture the SDOH, we had to have it all on one. So what we ended up coming with, which is a huge, point, I know we covered it in previous, but in terms of summaries of lessons learned for us, has been try to capture it all on your EHR. And what we did was we purchased another, it's another practice, they called it. And it's added to our EHR, but the practice now is SDOH. So on the screen, let's say a provider sitting there, pediatrician, he's pulled up our NextGen system. There's a tab up on the right side that he can push, and that tab takes him to the whole SDOH fields. And then, of course, being able now that, how many different departments, staffing levels have been trained on how to capture, how to interact with the patient, how to elicit this data from patients without promising the moon, right? And you have to be realistic too, and then push it to the case managers, the referrals team. All aspects of our organization, all staff are involved in SDOH in some way. So that's another huge point. And again, I know we covered the culturally competent staffing, how that's so important to work with patients and clients around SDOH. Otherwise, people might not want to tell you what their needs are if they don't already trust you. That's another huge one. And then how do you analyze the data to be able to further advocate for the implementation and payment of SDOH services? And that's been one of my big purposes, I think, to continuously push information back, studies that we've done, correlations that we've made about all aspects. And I know we could continue doing this for many, many years. Asthma is one, liver clinic with hepatitis, the medication, adherence, all that kind of stuff is another one. Just so many. And everybody is impacted. Our basic research study that we did was part of my dissertation, and it was again to monitor and measure from the perspective of the patients what the value is of having SDOH services. And you know, one of the biggest outcomes was, well, because it connected them to a support system that they knew then that they could rely on somebody there for other needs that present themselves. And aside from that, they got all of their survival needs met, and they feel like they're in a much better position in life. And they now have some hope because they've gotten some of these major challenges addressed. So backing that up, again, triangulating that data with hard evidence from the quality metrics, from the HEDIS, you know, it's all part of establishing that, you know, that basic finding that this is really incredible, very necessary to improve people's well-being, which is the ultimate goal.
We have a comment by Andres Uveta. He says, we currently use NextGen and it's supported by the Prepare template, which is built into the EHR.
Yes, La Maestra was in the first pilot project with, you know, for the Prepare through NAC. We already had our templates that we were using, not through NextGen. And, but for us to really migrate all of the data, and we collect a lot more data that's on the Prepare template, because, you know, based on the needs of our populations and where we are now in our journey with integrating SDOH, we found that we needed to have a much more robust, you know, set of fields, right, by the different sector of need. So that's how our NextGen got really expanded. And again, we purchased another practice under our enterprise for SDOH. So you might want to, you know, inquire with NextGen, you know, what that would look like for you if you wanted to expand that.
Great. I'd like to open it up to everyone. If anyone has any questions, to either add them to the chat or unmute or raise your hand and we'll unmute you.
I think that, you know, if we see now, you know, managed care plans and managed care being transformed into, they call it ECM, expanded care management, case management. Again, it's all looking at how health plans can save money and incorporating SDOH that they will pay for their very complex need patients that are costing them a lot. And if that's the hook we can get into, you know, and then keep expanding it to where all of the patients or all of the members, not just the high utilizers or the high costly patients, all members could be taking advantage of these SDOH, and we would be paid for them. That's the goal.
Peter, do we have any questions or hands raised?
No, not at the moment. Oh, yeah, no.
Okay, well, I would like to thank Zara very much for all of her experience that she shared and all of her insights today, and to all of our previous speakers for making these learning collaborative sessions so useful for our attendees. And also thank you to everyone that's attended for sticking with us. 5 sessions is a lot, and we hope that it was valuable for you. I do want to point out a resource from ARC, AHRQ, on identifying and addressing social needs in primary care settings. So you can get that resource as a link on these slides. I am going to launch the evaluation poll, and just a reminder that I will be sending you an email with the link to the SurveyMonkey as well. Here is the evaluation poll for this session. Chantel, you don't have to read this one out. I'll just ask folks to answer it. and I'll keep it open as we go into the next slide, which shows the link to the evaluation survey, which I'll also email to you. And again, just thank you so much. Oh, we did have a question from Andres. He's asking about if anyone's using Nowpal. Is anyone, Andres, do you want to describe what Nowpal is for the folks who don't know who it is?
Can you guys hear me?
Yep.
Oh, so Nowpal is just a different platform. It's a centralized platform where different community agencies can join, and it's basically a referral sent out to those agencies based on the SDOH needs of patients. So if it's a food scarcity, it goes to the local, like the food bank or different food pantries, and it's a direct referral, and they have the option, obviously, of accepting it, assisting the patient, and closing the loop by sending it back to the health center. This patient was assisted. So it's kind of closing the loop overall of not just sending patients, not knowing if they were assisted or not. So I'm just curious, because we're going to be transitioning to Epic in the next couple months, and we're going to be utilizing Nowpal for our SDOH referrals. So just kind of trying to get a sense of that.
Yeah, that's very important, closing the loop. We in San Diego have this 211 project that used to be the county's call center. And we get tons of referrals from them for all of these services, but they don't really keep track of, what ends up happening. We would probably end with more information than they would, because they're kind of just like a referral call center. The other issue is that since cyber attacks are really prevalent in the health field right now, ransomware attacks, cyber attacks, many health organizations are limiting the amount or the number of partners where they share PHI, protected health information. So like, for example, La Maestra has enhanced our cyber security plan to only share PHI with other healthcare, organizations, obviously the hospital is a specialist, so forth, and with the county, public health, government, funders, and so forth. So we're really not interested in having, let's say, a data exchange with the, with a 211, for example, a call center, because of that risk. We've had, numerous attacks on the healthcare sector, and it's getting worse because the criminals are much more effective at really stealing people's identity if they can get a hold of health records, much more so than the credit card information. So that's just some caution I'm putting out there, with building interchanging, connectivity, and sharing bridges and so forth.
We do have a question by Aaron, and also Denisha Reed shared something in the chat. So the question by Aaron is, has anyone used a screening tool like Prepare as a pre and post assessment of SDOH needs in order to demonstrate outcomes after referring or providing SDOH services?
Excellent question. We've done that with in our programs, like, let's say, asthma clinic, diabetes, and so forth, to really try to get a baseline and then be able to show, right, the outcomes and the improvements, and that then we could build those correlations to, it's because we had the SDOH services, right? And I think building those baselines, establishing them, and then going back and measuring the differences is really important on any new program that you're initiating.
So we have another question by Denise.
Just real quick, I just wanted to mention, I was on a call earlier today with the Michigan HCCN, and I think HCCN stands for Health Controlled Care Network. And they use Prepare. They're developing a risk stratification model using Prepare. And I can add the contact information for that gentleman on in the chat, and you can kind of follow up with him about how to do your risk stratification using the SDOH data. And Prepare.
Okay, we have the other question by Denisha, and it says, I have not used it for pre and post evaluation, but that's a great idea. The biggest barrier would be to get the post data, and if the patients you serve are more transient, then it might be harder. How do you envision implementing the pre and post?
I had put that because we were talking off to the side, but I Zara had answered it about I guess how you are getting that pre and post and making sure that it is matched with the right person versus like the entire, you know, health center population and whatnot, and making sure you're able to say that because of this program or this intervention that was implemented, you have seen a change in that. Unless you plan on doing it for all your health center patients, of course, at, you know, their annual visit or some type of, you know, time frames, just thinking out what that will look like based off of the program or intervention you plan on implementing.
Right. The other option is to see if the health plans will share with you their utilization, and therefore you can see, you know, well, you know, are they spending less on your members, you know, and why? Because they have all of those categories listed in their reports of the costs by member.
Thank you. That's a great idea.
Do we have any other questions?
Oh, we don't have any additional questions.
Okay, well, thank you again, everyone, for joining us for these sessions. On behalf of the National Center for Health and Public Housing, I'd like to thank everyone again, and we will follow up with you by email with slides and recordings and surveys. And please let us know if there's anything else that we can do for you. So thank you.
Thank you so much. Have a great day. Bye-bye.
You too, bye.
Thank you.
Bye.